It Out Loud, a podcast by Chasing the Rainbows with your host, Bernice Quisenberry.
On this week's podcast episode, we are doing our Ask a Maternal Fetal Medicine Doctor segment, and it's with Dr. Serena Wu, MD, and Fellow of the American Congress of Obstetricians and Gynecologists. She is a maternal fetal medicine specialist who experienced her own baby loss, and we can't appreciate and thank you enough, Serena, for being here and to help our listeners and baby loss survivors get questions around their losses.
No, thank you very much for having me on this segment. I truly enjoy being here with you and being here with everybody who's listening to just chit chat for the next 20 to 30 minutes.
Yeah, absolutely. And I think, putting things into terms that myself as a baby loss survivor who, can understand and different things to ask and educate myself on, for that awareness. So when I go in and talk to my doctor or, talk to a specialist, you can go in feeling a little bit better, knowing a few things to bring up.
Right. Absolutely. And I always think that medicine always sounds really scary because of the words, and in actuality, if you break it down, it's not that scary. I mean, it's scary to have anything going on, but at least going in with the the obstetrical care that you're looking for, and what questions to ask if you don't know what is coming up or what you should be looking for. That's always scary when something pops up, and people don't talk about the negative stuff or the possible negative stuff. And when it does happen, then it's all of a sudden you're going down another path, and all of a sudden those expectations of what you thought you were going to have or what you thought your pregnancy was going to be like is not the same anymore.
Right. And, especially being pregnant after loss and going in and you go in with a whole new lens and you see things completely differently, and you don't want that unexpected feeling to happen again like it did or could have, during your loss. So anything that we can do to almost armor ourselves to go in and feel, more confident when we're talking to our provider, and just, having that, behind us and knowing that, other baby loss survivors understand what they're going through and things like that too.
Exactly. Yeah. It's hard. And we try to control as much as we can. And sometimes it's just not controllable, but at least if you have someone you can talk to who can break it down, other people that you can, like your group, can support during the pregnancy, after the pregnancy, through the pregnancy. I mean, I think that's super important.
Yeah. Oh, thanks so much, Serena. Yeah. And just, before we do dive into what we're going to discuss today, I just want to give a quick disclaimer that we're not giving out medical advice, medically treating any persons, medically diagnosing any persons, and providing second opinions, virtual consults. And we're not doing any of that throughout our entire podcast. For medical advice, treatment, or diagnosis, please consult your primary care physician. This segment is just to give some peace for our listeners who are struggling, and to open the dialogue up and have the ability to not feel judged and silenced around our losses. So our sole intention is just to help survivors process their traumatic loss. So we are continuing our discussion from our previous segment. We did it during season 1, episode 25, and season 2, episode 5. And it's on 18 things physicians and patients should question. That was published by the Society of Maternal Fetal Medicine. And we encourage anyone listening in to write in with any further questions that you have from our discussion. And you can do so on our website. And, Dr. Serena and I will definitely, do another episode and to address those. But just to continue to where we were at point 5. And then our last segment was really answering questions that people had from the first segment from 1 to 4. So point 5, don't perform routine cervical length screening for preterm birth risk assessment in asymptomatic women before 16 weeks of gestation or beyond 24 weeks of gestation. So, what is cervical length screening? Let's start there, Serena, if you don't mind.
Yeah. So, screening is where we basically means we look at the whole population. And so, like, if you were going to screen a population for chickenpox, how do we do that, for example? And it's a test that sees who has been exposed to chickenpox. So, just going with my prior example, you want same for, like, if you're trying to screen somebody for deafness, there are tests to test for deafness. It doesn't mean that you're actually deaf. It just, are you at high risk or not for being either having chickenpox or had chickenpox, or if you're high risk or not for possibly not hearing as well. And then there are other tests thereafter that would potentially diagnose you. So screening is a test that we use to identify, is there a possibility that you could be at risk for, and specifically for this point, at risk for having a preterm baby, going into labor early and having a preterm birth. And how do they do that screening test? How do we do that? And right there, the wording cervical length. Cervical length is, you can say it in many different ways, but is the length of your cervix. And how do we find the length of your cervix? The length of your cervix is, we look at it via ultrasound, and that's the only way to figure out the length of your cervix by a measurement. We could try to feel your cervix, but that is an estimation. That's not the actual image of your ultrasound. And why we use cervical length as a predictor for preterm birth is that the normal length of a cervix for any woman is anywhere between 3 to 5 centimeters. Now, your cervix can be more than that, and your cervix can be less than that. But typically, the normal range is 3 to 5 centimeters. And when you go for your ultrasounds to look at the baby, measure the baby, we look at different things of the baby. Another thing that we look at is your cervix and how long it is. And that's part of normal screening. So when you go and this is always very fascinating to me. An ultrasound is really a test. People don't think of an ultrasound as a test at all, because you're going to go see your baby. But it actually is a test, and it's a screening test. We are looking for things on that test. We're looking for things on that ultrasound that could highlight a possible problem. And it's very, it's a shift in how you think, that, the ultrasound is actually a test. And I think the only place that we think of it not as a test is actually in pregnancy, because you're so focused on looking at the baby and, am I having a girl or boy? And how much does the baby weigh? And I get a lot of questions. Well, can you tell me how long the baby is? I mean, so we never think of the ultrasound as an actual test, as a screening test. We actually think of it as, hey, we're going to look at the baby. So yeah, I mean, so and then the reason why we use cervical length to predict possible preterm birth is that the shorter your cervix, the higher the possibility that you may go into preterm labor. And generally speaking, I mean, people use different cutoffs for that possibility, or that percentage of women who might go into preterm labor. But generally speaking, less than 1 centimeter, I think across the board, you get most MFMs that would agree that is at very high risk for going into preterm labor. That's usually the cutoff that most MFMs would recommend some sort of intervention, definitive intervention across the board. argue about 1.5 centimeters, 2 centimeters, 2.5 centimeters, but I would think anywhere between 1 to 1.5, people generally think, yes, we either need to do something like a cerclage, which is a stitch to close the cervix. Definitely people would talk about progesterone to a vaginal progesterone as another intervention as well. So that's why this is cervical length screening for preterm births, and that's what this is specifically pointing to.
Okay. And they're saying then, as long as you're not showing symptoms, that there's no need to do it before 16 weeks or after 24 weeks of gestation.
Yeah. So, and this is asymptomatic. It has I believe, a couple of meanings here. So,
Okay.
meaning, right, no, that there's no signs of labor, which you typically don't get. You don't get a lot of cramping. If anything, there might be bleeding that people might see. There's a first trimester spotting is something that people do see quite commonly. Most often, it is benign. There's when you have chronic bleeding from the first trimester on, that may not be benign, but having some spotting, then having it go away is a very common symptom in the first trimester. But asymptomatic women, also can mean that someone who's never had a preterm birth, and this is their first pregnancy. So there's nothing going on. Screening are we going to predict? Can we predict that this person's likelihood of preterm birth in someone who has no symptoms and someone who has had not a prior preterm birth? Please don't do a cervical length. Don't measure the cervical length before 16 weeks, and stop doing it after 24. And that hits. The reason for the 16 and 24 is that typically the recommendation is to do it between 18 and 22 weeks, where you get one ultrasound to do your anatomy scan, and in that ultrasound, we also look at the cervix as well as the other organs that are, or the other structures that are there. So like your ovaries, we actually do look at your uterus. So we make sure everything is also, that there's nothing going on with your ovaries, that you don't have any other things going on with your uterus, meaning is it differently shaped? Does it have fibroids in it? Things like that.
Yeah, that makes complete sense. Thanks so much for explaining that, Serena.
Yeah, I mean, that statement is so simple, but yet you have to like
break it down.
Break it down. Yeah, completely break it down. Because it's like, well, why? Why
exactly
are you doing that?
I know. Because I was thinking, what is the 16-week point at 24? Why is that? But it makes complete sense once you described it. So appreciate that.
And then the other thing is that if someone had a prior preterm birth, you would do that first cervical length possibly by 16 weeks. I mean, you could do it then, and then you would keep going until about 24 weeks. And then after that, the recommendation is not to continue looking at the cervix even after 24 weeks. And really the recommendation is to do a digital exam to feel the cervix, not to keep looking at it via ultrasound.
Okay, that's good to know.
Yeah, you'll find this is where many MFMs and many OBs do not agree on these points, and people individualize as well. So,
and that's right, taking in that individual factor, and every pregnancy being different, every person being different. So you're right, Serena, and I think that's a valid point, to bring up. Absolutely, yeah, and every MFM and OB is different.
Yeah,
and,
absolutely.
Practice and what they do. Right. So it's really just trusting your doctor and trusting the process. Right.
Right.
Yeah. All right. Point number 6, don't perform antenatal testing on women with the diagnosis of gestational diabetes who are well controlled by diet alone and without any other indicators for testing.
Okay. So this point
So,
is here
yes.
because we used to do antenatal testing, and I'll tell you what antenatal testing is in a second. On all women with gestational diabetes, whether whatever method that it was controlled. And antenatal testing is just fancy for doing a test that ensures in your doctor's mind, and hopefully in your mind, in the patient's mind, that everything is good with your baby for the next week and for that day. And so those tests that we can do are biophysical profiles, which is an ultrasound that we look at 4 different components that the baby does, which is breathing, practicing breathing. They're not really breathing, they're just practicing. 2 different kind of movements, and then what the amniotic fluid, how much amniotic fluid you have within the sac. Or within the uterus that is around the baby. And we're specifically looking at a pocket. So it's not just total amniotic fluid. It's actually, do you have a 2 by 2 centimeter pocket? That's an ultrasound evaluation of a test. The other is what we call a non-stress test. That's where you have monitors that are like the size of a hockey puck that are put on your belly. One is to record the baby's heartbeat. The other is to record your contractions. And it should look a certain way beyond 32 weeks. And that can be a whole nother discussion if people want to hear about what a non-stress test is and when should we be worried. But those are the 2 tests we typically use for antenatal testing. And why we do it is that it can reasonably predict, it's not fail-safe, but it can reasonably predict the possibility of an adverse outcome. And usually that means perinatal death, it means fetal death within the week. So if your testing is reassuring, either one, the likelihood with an adverse negative outcome within the week, when you repeat that test, is really darn low. It's like 0.01. 0.01. Yeah, 0.01, 0.02. It's pretty low when you combine it. And it might be even, I might be exact. Maybe it's 0.1 and 0.3. So pretty low, 0.1 and 0.3%.
Yeah.
Now, we do this testing on people who are high risk. Their pregnancies are high risk for having an adverse outcome, like, for example, a stillbirth. And things that can put you at high risk for that is actually if you had a prior pregnancy with a stillbirth that's otherwise unexplained. If you have a pregnancy that's complicated by high blood pressure, specifically with this one, if you have a pregnancy complicated by gestational diabetes, which is just medical jargon for diabetes, it's only in pregnancy. Your pregnancy is high risk if you have diabetes that was pre-pregnancy. And there's a whole host of many other things. There's like lupus, uncontrolled thyroid disease, renal disease, if the baby is growth restricted, if the baby has an anomaly. I mean, so there are different things that can make your pregnancy high risk for having a baby that ends up not doing well or ends up in a stillbirth. And that's why we do the testing, is for those women, even, for example, advanced maternal age. Just that alone would get you what they would do antenatal testing at some point in the pregnancy, and we would do it weekly thereafter, kind of would be the recommendation. Now, this specifically is pointing at the fact that gestational diabetes that you don't need to take any medications for, meaning you are controlling your blood sugars just because you corrected your diet or just changed your diet to lower carbs, more protein, and just by tweaking it here and there, the numbers are where they should be. And that's really good. Your risk for having a stillbirth is actually no different than a woman without the diagnosis of gestational diabetes. And so what they're saying here is because that risk of a stillbirth is no different, that you shouldn't need to do any testing. And why they're pointing this out is the reason is that we used to test all women with gestational diabetes, whether your diet alone controlled or whether you needed medication. But just within the last 4 to 5 years, they have found that women with very well controlled gestational diabetes that requires no medications, their risk is no different. And so they shouldn't need to come in every week to have this extra testing done.
Yeah, that makes sense. Absolutely. And two, I think it's good to point out that it can be controlled. Like this is for specifically when it's controlled through diet and not through needing to like the medication, like you mentioned, and things like that too, Serena. So
yeah,
that can actually happen, right?
Right. I mean, and without other indications for testing. So that also means, is there too low fluid? I'm just other indications
Right.
that might get you to be tested. Like how much amniotic fluid do you have? Is it too much? Is it too little? Despite being well controlled, despite this one factor in your pregnancy, is your blood pressure starting to creep up? Are there other reasons that we need to, see you, age? I mentioned age. So you might be 45 years old. Well, we're going to be testing, irrespective of the gestational diabetes.
Yeah, that makes sense. And I think, is it also, Serena, is this an accurate statement? Not just gestational diabetes, if that's it, but they also look at other like risk factors and components, like you said, like your age or different things. And that all is taken into consideration to make that decision.
Correct. Yeah. I mean, if you're 45 years old with well-controlled gestational diabetes on diet only, you're still going to get weekly testing because 45 years old is another risk factor for stillbirth. And so we're going to, at least by 36 weeks, have you come in weekly at that point.
Yeah. No, that's good to know. Okay. So point number 7, that takes us to don't place women, even those at high risk, on activity restriction to prevent preterm birth.
Yeah, this is, I think we'll spend the rest of the time talking about this. It's really straightforward. I think it's the one that you'll find we all say it, but it's really hard to get people not to do it or not to say it either out loud to their patients. I think it's something that you think, well, that makes no sense. I mean, my cervix is a centimeter. What do you mean I should still go to work? What do you mean I should not be in bed? I had a baby at, I don't know, 32 weeks, and now my cervix is short. I'm on vaginal progesterone. What do you mean I shouldn't be on bed rest? And it's just intuitively you're thinking that makes no sense. I should be not. And I would say, common sense would say, well, don't go run a marathon, don't go, do shred or CrossFit. You probably shouldn't be doing the high impact exercising. You shouldn't be out there doing your normal like gardening or, but you shouldn't stop activity either. You shouldn't be on bed rest. This is just really saying, don't restrict your activity in the sense of bed rest. Do not put yourself on bed rest, because actually bed rest is more harmful. And they have had multiple studies that has shown that bed rest doesn't, for those women at high risk and for those women, at high risk on bed rest versus those not on bed rest, in actuality, there was no significance, statistical significance in the outcomes, meaning preterm birth. And what we end up doing instead is creating more issues with possibility of forming clots. So more morbidity instead when you go on bed rest, because when you're pregnant, and we might have talked about this before on another segment, pregnancy is a hypercoagulable state, and it's nothing that, that it's just the pregnancy physiology. It's nothing that we do to ourselves. But we are more likely to develop a clot in pregnancy than we are than we are when we're not pregnant. And so there are certain things that put us at higher risk for clots. One of them is lack of activity, bed rest. So that's another reason why we don't advise it, is that there tends to be higher morbidity at bed rest. And then 2, research hasn't shown that bed rest is beneficial. But it's hard to say that, right?
I know it is, because it doesn't feel right. Actually, like even saying high risk bed rest, like it makes sense together, and saying, no, don't do that. But then hearing, the blood clots and different things and how it can be a lot worse than just having some mobility, not doing anything intense. But I mean, and that's all up to, right, like the individual and the pregnancy and, what the provider thinks. But that is interesting, Serena, because that caught me off guard a little bit.
Yeah. It just, we try not to do it. and patients always ask, are you sure? No, really?
Yeah.
It's hard.
I think it's scary. Yeah.
Yeah. Yeah. And I think people do it anyway. Like, even if I were to say, no, you shouldn't do bed rest, I think they go home and do it, try to do as little as possible. I think it's harder to be on bed rest at home, because I think for most people, it's like, oh, I can get up and go do this. I can get up and, I'm not going to wait for somebody to get me something when I can get up and do it myself. It's really hard. Bed rest at home is really a hard thing.
Yeah, because like in the hospital, you're forced to be on bed rest. If you're there and you're in, there's nothing you can do. There's no household chores. It's like the room is a controlled area. But then when you get home, there's all those external factors around, pets or, cooking and cleaning and laundry. That's not going to do itself. So I know it's like easy for you to get distracted and to do things by accident if you are on bed rest. Yeah. No, I get it. No. Oh, well. Yes, Serena. So we got through 3 points. I can't thank you enough for being here and for sharing all of this for our listeners, and for them to hear, just to go in, to educate, to advocate, like we say. So thank you so much, Serena.
Yeah. And we still have about 10 more, 10 more points to go through. But the other thing I wanted to throw out there was if anybody wanted us to do a specific topic as well. So if somebody wanted to do like, cervical length, or someone wanted to do like the anatomy scan, or somebody wanted us to talk about gestational diabetes or gestational hypertension or preeclampsia, I think those are great topics that, maybe it just wasn't explained, just hearing it from different people, and how, I mean, I still learn quite a bit from my colleagues. I love listening to other people counsel patients or talk about these different things, because I think you learn how to talk about it in a different way that maybe can break it down a little better for your patient, help them understand why you're recommending what you're recommending and why you're worried about whatever it is that you're worried about. But I would welcome and throw out there for the listeners that if there's a certain topic, I mean, I love this article. This article I think is something that, breaking it down and then having that knowledge, because some of these are this is normal prenatal care, and you might not know why your doctor is recommending some of those things that are listed on here, and having that, this is something that is nice to talk about, and we spend half an hour just breaking down only, three points. But if there's something else, we can certainly come back to this and address a topic that someone wants to discuss the next time.
Yeah, and I think that is really important. When you go in for doctor's visits or, things are happening around you, I don't always think about the questions to ask or to follow up with because you get hit with this information and you're just trying to absorb it and remember why or,
Right.
remember certain things. So when you get home, it's nice that, someone could write in and ask us questions about it for our segment, because if they forget to ask their doctor or forget to mention it or, forget to send it through their my chart or whatever the case is, and just like talking through it a little bit more and to get it's nice to get, various voices and to hear, different people explain it, like you said, Serena, because I feel like certain things stick with me when some people explain it versus others. So,
Yeah,
yeah.
absolutely. Yeah.
And sometimes I have to hear it a couple times to process it.
And that's definitely I agree with that too. I mean, I agree with everything that you've said, but
Oh,
it
yeah.
it especially when all of a sudden your pregnancy has derailed and is going off in a different direction, it takes multiple times to hear and understand what is going on to really like, okay, I get it. Okay.
Yeah.
I see why, now I have to do this because my blood pressure is, 130s to 140s, it's not where it should be. Or wait, why do I have to, have an MRI?
Yeah.
And why do I have to deliver by C-section now versus I wanted to deliver vaginally, I mean,
Yeah.
it might take a few times because the shock of the first time when you were told you can't do that anymore.
Yeah. And it is that. And I think, with pregnancy after loss, specifically just speaking for myself, um, you're reliving all your triggers, from
Right.
the previous pregnancy, of everything that we went through. So when I would hear different things, it was hard not to almost have that fear. Are we going down this road again? And to the unexpected, like we did previously. And I think, you know, hearing some things is a little harder. So it is good just for processing wise for myself to just keep hearing different things and hearing it from multiples. So I think that's why it's so important to have you here. Yeah.
No, thank you.
Thanks, Serena. Oh, I can't thank you enough for being here. And yeah, I hope our listeners take us up on that. And I'll keep an eye out and just feel free to write in on the website. And we just thank you for tuning in. Please follow and subscribe to our podcast to help us reach more survivors. And we're always with you, infertility, pregnancy loss, and infant loss survivors. And until next time, thanks again so much, Serena.
And thank you for having me.
Yes, thank you.